The 12 rules to live by on testosterone. Today, rule number 6, increased red blood cells, because this is so common. Actually, it's been cited that this is the most common side effect in research studies for men on testosterone, increasing red blood cells. And we're going to talk about that. I actually have a playlist here on the channel called Increased Red Blood Cells on Androgens. And you could see that, and we're going to, of course, add this to that list. This is complicated. This is so complicated that I'm doing research with a hematology doctor right now because we have to understand this. The mechanism of action first is something called testosterone or androgen-induced erythrocytosis. And when you look at this mechanism, when you look at the research on it for how we think what happens, it's not very clear, actually. Even to today, it's not fully clear. Testosterone goes in the body and it stimulates your body to produce more red blood cells from the bone marrow in the end. Let me get excited here for a minute, guys. Let me get excited because let me do the best I can to explain how I see, from my perspective, what I think is the overall mechanism of action that's so important. So you see a new set point. They call a new set point of between the recalibration point of erythropoietin versus hemoglobin in face of increase of iron utilization for erythrocytosis. Let me explain what's going on with that. When men first initially take testosterone, the erythropoietin levels normally come out. These are from the mechanism of how you build red blood cells from a normal kidney. It stimulates that, and then it goes up, and then you produce red blood cells more. You just make more hemoglobin because it stimulates on the bone marrow itself, a healthy bone marrow, and it starts to increase red blood cells. So that happens from androgens. And then what happens is you're suppressing another peptide, another incredible growth factor in this incredible medium and this methodology of mechanisms of action of producing red blood cells. Hepcidin goes down, it's suppressed. So initially you see EPO goes up, hepcidin goes down, but over the course of the first 6 months or so, based on some of these studies that we've seen, there becomes a shifting to the right, if you will. There's a recalibration because in face of having an elevated hemoglobin, the erythropoietin levels should go down. They should be suppressed. They're not suppressed. They go back to normal. They don't always stay elevated, but they're not suppressed. So that's a right shift. And that is in face of an increase in iron utilization where you're sucking out, you're taking this iron from your body and your stores. We'll see that in a minute. Ferritin levels, it goes down for many men. Of course, not men that have underlying genes for hereditary hemochromatosis. I've discovered this, and this is such an amazing discovery with other doctors that what happens to that? You're going to iron saturate. You're going to have iron deposition in your body, and that's going to be as if you had a disease state called hereditary hemochromatosis or polycythemia vera, and then you're at risk for depositing iron with secondary to a position of having too much red blood cell into your body and depositing into your brain, your heart, and your liver. Not to mention your testicles. Men that have hereditary...
Hey guys, quick pause here. If you're watching this video, odds are you're concerned about your testosterone levels. That's where the sponsor of this video comes in. Let'sGetChecked.com. Let's Get Checked makes professional health testing easy by letting you get tested without having to visit a healthcare provider. Choose your test online, like one of their testosterone panels, and it will be delivered to you in discreet packaging with next day delivery. Once your sample arrives in a laboratory, confidential results will be available from your secure online account within 2 to 5 days. See my link in the description for more details and discount code.
Depositing into your brain, your heart, and your liver. Not to mention your testicles. Men that have hereditary hemochromatosis, that organically they have actually low T because of years of having this. It destroys the Leydig and Sertoli cells. I'm not kidding. This is an integrated feed, and it's so complicated. Of course, we're talking today about men on androgens. They don't have low T, most of these men. They're giving themselves testosterone, or if they have low T, they have it from cardiometabolic reasons, right? Or from maybe drug abuse or including steroids. So this is the amazing point in the mechanism of action I want to get across here for all you technicians, and you guys know I have to start off with the technical side and the mechanism of action. So again, increased erythropoietin, suppression of hepcidin, new set point shifting to the right in face of increase in iron utilization for erythrocytosis, and then you see guys living with different degrees of hemoglobin hematocrit elevated. We're going to go into all the numbers coming up here, and you're going to understand what you can do and what's dangerous and not dangerous. So that's the mechanism in face of iron utilization for erythrocytosis, artificially, exogenously from testosterone. Beyond the mechanism of action, what's going on? There's a strong genetic force here going on. There's a variable gene for hereditary hemochromatosis. There's multiple genes. Of course, there's one or two main genes. Men from Northern European ancestry are most at risk. And indeed, when you see men, Caucasian men from Northern European ancestry backgrounds, they're very sensitive to androgens. Amazing. So this is, you could see where I'm starting to give you the information. So if you're a Caucasian man, European Northern ancestry, if you have hereditary hemochromatosis in the family, you're going to see, I've seen it. This is rare to see guys that happen to be using testosterone or steroids and they have a direct history directly of their dad or maybe an uncle. You're going to see these things. The red cells will go up, and that's going to be directly dangerous. I've seen a very small number of cases, but I have these cases out of thousands. Number two is age. Another risk for this excessive erythrocytosis, if you will, or this polycythemia, the increase in red blood cells on testosterone for you guys, is age. Don't see it on young men. Young men can take 2 or 3 grams of testosterone. Red cells are normal. Then you give a guy little baby doses of TRT and he is 40s or 50s or older, red cells through the roof. We don't understand that at all. Beyond that, what else is going on? The obvious dose of the testosterone, the ester itself, versus cream or HCG, Clomid, and then I talk about, obviously, NOR19 drugs, equipoise, decadroboline, Tren, even Anavar on women. You see women taking little baby doses of Anavar, Primobolan, and some of these lighter equipoise, teeny doses of EQ for women. These are the drugs that women use. You can see their red blood cells, they go up. They go up. So again, this is a conserved mechanism of action across the mammal, if you will, the human, with the androgen. Number 4, what else is going on here apart from that scientific mechanism? Obstructive sleep apnea. This is huge for you guys to understand. Wait, there's a hypoxic induction component built into this mechanism that I talked about with stimulating the erythropoietin, suppressing the hepcidin. There's a built-in hypoxic induction, big time, huge. Smoking, so you see smokers have increased erythrocytosis and increased red blood cells. Commonly, women and men, they just, wow, you're outside the reference range. What's going on? Take a history. They smoke. You see them upper limit normal. Living at a high elevation. So I got to imagine I have a guy who's got some genes for this. He's on testosterone, maybe too much. Maybe he's living at a high elevation in Colorado and he smokes. I've seen it all, guys, seen it all. Next, number 7 here is diet. So red meat, there's no question there's going to be an implication for the diet. You know, plant-based diet versus red meat and organ meats. And I'm not against meats. I'm just giving you scientific information here. So, okay, that's beyond the mechanism of action I call. Most importantly, you guys want to hear, stay in touch here with this and focus on this stuff. Risks. What actually are the risks, doctor? I mean, people have it. You're going to die? What's going to happen? Well, here are the risks. Hypercoagulable state, potentially. Hypercoagulable, so increasing your potential for causing a blood clot. It's not good blood clotting. On the venous side, It's a deep venous thrombosis, classically in the legs, but I got a guy that's had him up in his arms, right upper extremity or left upper extremity, DVTs, more rare than lower limbs. So, and pulmonary embolisms, when you get deep venous thrombosis, clots in your venous system in the extremities, they can travel up to the lungs and end up lodging in the lungs. It's a pulmonary embolism. And that I can tell you from my hospital history of being a physician, that's deadly. That's why we give all these prophylactic drugs for people that come into the hospital for almost anything. And so that's the venous side. The other risk on the hypercoagulable state side is going to be myocardial infarction, heart attacks, and strokes. And even mini strokes or big strokes for that matter, and causing clots that lead to the eye. I've seen it, guys, and it's just rare, just super rare. I think the most common risk would be that hypercoagulable state, you're polycythemic, and you're concerned, or you've had a DVT. And that's one of the mechanisms. There's no question. Hypertension also. So it's always controversial. You have polycythemia, your red blood cells are up. If you really do have polycythemia, we'll talk about those numbers here in a minute. If you do, does it lead to hypertension? Hypertension, again, is multifactorial in its own right. So it can, I think, if you're, not to mention your fluid overload and you have plethora, which is your face is red and kind of puffy, not to mention from the estrogen, and now your red blood cells are up. And you guys have seen that look, right? Seen that look in steroid use. They have that purple kind of look, right? So it's just interesting. So that's really the mechanisms, that can lead to what are the risks are. Clinically, what do you see clinically apart from the risks that I just said for the blood clots? You'll ask a patient if you see polycythemia, do you have blurry vision? Do you have headaches? Those, and then that plethora, do they have that ruddy kind of a purple kind of a look, color to the face? So that's the clinical manifestation, if you will, in the risks. Management, what do you do, doc? Okay, so I have to watch for this increase in red blood cells. I'm on testosterone or steroids. What do I do? Here you go. Here we go. Management, what do you do? Labs are the mainstay. This is easiest part of the video here. Mainstay, CBC, right? So hemoglobin, hematocrit, and iron studies. Everyone knows about the CBC and the hemoglobin and the hematocrit. Everyone knows it. But a lot of guys don't integrate into the equation, into the monitoring, the iron studies. That has to be key. So the ferritin, the iron saturation, the total iron saturation and transferrin saturation, iron studies. And again, it's all on my website. We always lay these things out for you guys. You can understand those. I say them in multiple. On the app, I talk about this stuff all the time. So that's where you got to integrate the hemoglobin hematocrit with the iron studies. That's the chemistry for what you have to understand. You have to get a good history. You have to understand your family history of hereditary hemochromatosis, of blood clots. Maybe your mom or dad's had DVTs or miscarriages in the mom, or pulmonary embolisms, heart disease, sleep apnea. That's your history. Do you have sleep apnea? You got to get the good history. Now, so getting to the hemoglobin and the hematocrit, there's no one's going to argue me on this. No one's going to argue these numbers. It's amazing. If your doctor sees a hemoglobin of 17.1 grams per deciliter, oh my God, stop testosterone. You have polycythemic, you're going to have a heart attack or a blood clot. It's not true. It's not necessarily true. The upper limit normal of hemoglobin is 18 grams per deciliter. Some people even think a little higher. This is, again, upper limit normal for a regular person, not on androgen. And the hematocrit, 54%. But if you go to the common lab companies and lab carriers in North America, you're going to see a lot of them stop around 17, 17.1. Some, of course, go to 18, even higher. I think that's wrong to go higher than 18. I think 18 is the stop limit. It's my opinion. And most labs will stop. This is for men, of course. These are just for men. because men obviously come with the equation of being on board with testosterone from their testicles, natty men. So it's going to affect this, as I talked about, the mechanism, it's going to affect the difference in red blood cell production between a man and a woman. So when you look at 54%, that's normal. So a lot of labs will stop the cut point off, upper limit normal is 50 or 48. That's wrong. It's just wrong. It doesn't mean that you may want to keep your numbers down like there, but it doesn't mean that it's polycythemia. Go see a hematologist. All this information comes from board certified hematology. I'm just passing it along to you guys. There's no argument on the cutoff, 18 or 54. There's really no argument on that. And if you have an argument for it, let's see the comments. I want to see the comments on that, including doctors. I'd love to see the comments. Love to bring you on the show. Love to interview some doctors. I'm doing some research on that. Now, that's not the clinical aspect when you look at blurry vision, when you look at headaches, you have to rule that out from a host of other issues. But if you have a hemoglobin that's less than 18, for sure, less than 18, 17 to 18, and your hematocrit is under 52, under 54 for sure, your iron studies are normal, you have no medical issues, you don't need to excessively phlebotomize. I'm trying to give information directly for you guys on this. You have to go see a doctor and understand that if there's another reason why you're at risk for blood clots or cerebral vascular disease or strokes or, again, hypercoagulable states, your medicines you're on and your history, you have to enter into a dialogue with a doctor, someone like me, an internist that's going to understand the stuff. Again, you have to understand the iron studies. The ferritin is key. This comes right from hematology doctors. They don't get so impressed with the hemoglobin hematocrit. I'm not saying they're not impressed and they're not worried for you, but they look at the ferritin. And you'll see, as I presented for the mechanism of action, ferritins for most men on testosterone are low, unless you have iron deposition disease, hereditary hemochromatosis genes, the polycythemia. I'm telling you, it's so complicated. This is absolutely the most complicated video I've ever made. I want to keep it super strict and tight. I'm telling you stuff that's true, but as far as the end clinical manifestation with the data, we don't exactly know where the stop points are. You have to be careful. And if you have any disease, heart disease or blood clotting disease, you have to be careful on androgens, in part because of this, because it could lead to a hypercoagulable state. What do you do? Last part here, as I close, management aspect. What do you do? Lower the dose. Maybe go to cream or HCG or Clomid. It's less effects. The free testosterone, in my opinion, is king. The free testosterone is king with the injections, but the injections cause more polycythemia, if you will, and the erythrocytosis. You're just getting more free testosterone. So it's hitting this mechanism, as I talked about, with the erythropoietin, with that testosterone or the androgen-induced erythrocytosis, on the hepcidin, and across the board where you're sucking out in the ferritin. If you have elevated ferritin, you're going to have an underlying iron deposition disorder. You're going to worsen that on androgens. What do you do with that? You have to have a doctor like me or watching you, or a hematologist, and you're going to have to either not take androgen, take less androgen, and start phlebotomizing. But just indiscriminate phlebotomization for the average guy who's at a little TRT clinic looking at a hemoglobin hematocrit is cringy and embarrassing. You need to look at the ferritin. You look at the iron studies. What else can you do? Treat your weight sleep apnea. Use a CPAP machine. I told you that with the mechanism of action, there is hypoxic induction. That's living up on the mountain. Or if you're at sea level, that's having sleep apnea because you're not oxygenating at night. That has effects on the erythropoietin, on the increase in the red blood cells. You're on testosterone, that's going to exacerbate it. Change your diet. I talked about the red meat, plant-based diets. In the end, see a hematologist, and of course, You're welcome to come on my app, the Anabolic Doc app, where we have men, non-judgmental. I do the best I can with my medical information. I certainly don't know everything in the world. Sometimes I feel every day I know less and less and less because I realize just how complex all this really is. I hope this helps everyone get a great discussion because the red blood cells on testosterone are super, super complex and they can be deadly. That polycythemia, if indeed you have polycythemia with erythrocytosis in the hypercoagulable state, I really hope this helps. I want to get as many comments as possible, brothers. I need to see them. Men need to see them. We have to get good dialogue because, again, this is how everyone learns. Thank you so much.